Okay, good to go.
Hello viewers, today I am going to take. I'm pretty sure that after watching this video, you will have better understanding of.
ये किसका आ रहा है?
Dr. Manoj. Okay, Vineet, we are good to go.
Yes, we're starting, boss.
Yep.
Hello.
Can you hear me?
Yeah, I can hear you. Mahindra, boss, shall we start?
Sure.
Yeah. Good afternoon, everyone. On behalf of DOA, I welcome all the delegates and panelists. Today is the 14th EPG class of DOA, and we would like to discuss an approach to the clinical examination of elbow joint by none other than the Professor Lalit Maini. He is a well-known orthopedic surgeon with a national and international repute. He is presently posted as a director professor at the Department of Orthopedics of MAMC, New Delhi. He is a full-time faculty with a teaching experience of more than 25 years. He is presently holding the post of editor of prestigious IJO, and he has many national and international publications in his name. He was honored by a prestigious Ranawat Best Paper Award in July 2006. And he has been an examiner to all the many PG ortho examinations and has been a main force behind many courses started in the DOA. Many courses started back at DOA. He is presently a president-elect of DOA for the next 1 year. And we have got another extreme panelist, Dr. R.K. Manocha, who has been working as a senior consultant at NRCH Hospital, New Delhi. He has more than 20 years of clinical experience, and he has special interest in shoulder and knee and elbow joint. So now, without wasting much time, I would hand over to Dr. Professor Lalit Maini. Kindly start his presentation. Thank you very much.
So is my screen visible?
Yes, sir, we can.
Yes, it is visible. Sir, can you
Thank you.
full screen?
Thanks a lot, Delhi Orthopedic Association, for conducting these nice programs for the postgraduates and also for others who are updating their knowledge in these difficult times. So, as Vineet has already introduced me, I'm working as a director professor in Maulana Azad Medical College, and I'm a graduate and postgraduate of the same institute, and I've been serving there for some time now. So today's discussion would be on how to evaluate an elbow joint. This being a very, very important topic because it is a very, very important case in the exam. And it is also a common area of problems with which patients come to clinics. So let's start. What's happening nowadays due to the remote counseling, the teleconsultations, and even otherwise the change in behavior of both and doctors and patients. What happens is you get a picture on WhatsApp like this. And the question is, what's your opinion? And you start looking at the X-ray. And if I have to describe this X-ray, this is an X-ray of the elbow joint of a skeletally mature person. I can't say whether it is right or left. And it shows a fracture in the distal part of the humerus in the supracondylar area. There is a lot of proximal migration, as you can appreciate in the AP view, and that's about that I can tell you. The fracture line is still visible, and the distal part of the humerus, the fracture is sharp and poking forward. Otherwise, the bony architecture seems to be fine. So with this information, it becomes really challenging to give an opinion on what can be done. It doesn't tell me anything about the name, age, sex, occupation, the marital status, the residential address, and the date of injury or whatever happened to this patient. So suddenly you realize the things which seem to be boring, the patient details, suddenly become important when they are not there. So the person sends you a picture now, and he says, okay, I'm sending you a picture. This is a picture of the patient, and he has a complaint of a painless stiff left elbow. So I'm sure now you can see few more details of the same patient, and it definitely shows you a huge scar on the outer aspect of the elbow and the forearm, emphasizing that probably this is an old injury, and he's now come to you for a stiff elbow. But even looking at this picture, I really can't make out whether it is his dominant hand or not, whether there is a distal neurovascular at all, any involvement of the neurovascular. So even after having a picture, there are so many questions which are unanswered. And that is where is the importance of a proper approach to clinical evaluation of the elbow joint. That is why this topic has been kept in the DOA seminar. And these first two slides were to make you re-emphasize and make you understand that every aspect of the systematic evaluation of a joint is important. You understand the importance only when you're not told about it, and the fact which you didn't know had a very, very important bearing. So let's talk a few basic things about the elbow. What is the primary role of the elbow? The primary role of the elbow in the upper limb complex is to help position the hand in the appropriate location to perform its function. So it's basically assisting the hand function, whatever the hand wants to do, by positioning the hand in a place where the function has to be delivered. So this could be one of the major functions of elbow. Just to revise the basic anatomy, which is going to have a bearing in your understanding in the next few slides. There is a humerus proximally, there is the olecranon fossa posteriorly, the coronoid fossa anteriorly, there is the trochlea and the capitulum, the ulna and the radius distally. So the humeroulnar joint is like a hinge joint, but the radio capitular or the radiocapitulo-ulnar joint is a complex, you can say something like a pivot joint. So remember the articulations and the important bony structures. When you get on to the general approach to the elbow joint, as always in any other joint in orthopedics, you take the history, you do the examination, which would include inspection, palpation and measurement, range of movement, and then neurological examination of that limb. So this becomes a general dictum for most of the joints, and same would follow even in elbow joint. So let's quickly revise what are the pillars of history taking. Now, elbow would be invariably a short case, but with the changing scenario, especially with the remote exams which are happening now, and the exams which are happening with mock cases and scenarios, there is a mixture happening between short and long cases. This has already happened in DNB now, where there is no long and short case, and you actually have cases of equal marks. So the short cases are getting longer, the long cases are getting shorter, meaning a relevant history does carry a lot of importance even in short case. So the patient data, the presenting complaint, the history of present illness, definitely you need to ask in a short case. You might do the rest of it, the past history, the treatment history, and the social history in a less detailed way. But remember, try to tick all the 6 boxes so that you're not missing out anything. I'd emphasize this in the beginning. You definitely want to know the demographic data of the patient. the name is very important when you need to be polite and you need to be talking to a patient to gain his confidence. You talk to him using his name, the conversation takes a totally different level. You definitely want to know the age, it is connected to various pathologies, the sex, what occupation that does, because in elbow joint, the patient might have come to you because he's actually having some problem in his occupation. His marital status, which tells you about the support from the family, his residential address, especially in today's day, whether he's coming from a corona zone or any other zone, and when has he come to you actually, the date of admission or date of presentation. History of presenting illness is very important. You need to ask him when were you absolutely okay, and then try to take out the story, then what happened after that. There are certain patients who are going to tell you long stories, so you actually have to bring them back to the particular point and ask them, it is fine that you have been ill for ages, but what has brought you to the hospital today if your problem has been for ages? So you have to guide certain wandering patients to the specific points you want to come out with. So the common problems in an elbow case in the history which patient can present with would be pain, which could be secondary to a trauma or associated with fever. It could be swelling around the elbow. It could be stiffness, meaning limitation in the range of movement. It could be a deformity which the patient himself or the family has observed. And at times you want some additional history regarding massage and manipulation, which is particularly relevant for the elbow joint. And remember, as in any other upper limb case, it is very, very important to ask for the dominance of the hand. Is he a right hand dominant person or a left hand dominant person? Because the functional disabilities and the outcomes that you are trying to achieve will determine by and which side of the upper limb is involved. So these would be the common problems the patient would come with. And with any symptomatology in orthopedics, you actually want to know the onset, duration, and the progress. So you want to know how it started, what has been the course after that, and since when it has been there. Has the patient taken any treatment, and what has been the response of the treatment? And so you want to know the onset, duration, and the progress of whatever symptoms, whether it is pain, whether it is swelling, whether it is a deformity, whether it is anything else. So any symptom has to be elaborated on these three pillars. In the exam, the cases of elbow which come to you as a short case, I could say that 70% would be painless elbows. They would be sequelae of trauma, and the majority of them would be painless elbow pathologies. However, if you get a case which is a painful elbow pathology, your thought process totally changes, and the pain itself becomes a very, very important symptom which needs to be elaborated. So if you want to pick out the pathology guided by the pain, you need to go into further the character of the pain, whether it is a mechanical, inflammatory, or any other type of a pain. So once there is pain, in addition to the onset, duration, progress, you want to know the site, you want to know the character, you want to know the intensity, you want to know the radiation. So you need to know much more to categorize the patient under a mechanical, infective, inflammatory, or others category of pain. So this is a simple mnemonic which has been taught to you in undergraduation also, called Socrates. Each word has a meaning: S for site, O for onset, C for character, R for radiation, A for associations, T for time, E for exacerbations, and S for severity. So if you tick mark each part, you will actually be guided towards what you are dealing with. And you would like to know other characters about pain, whether it is unilateral or bilateral. At times, the patient might come with a severe elbow pain, and when you probe further, he might tell you that he does have certain amount of pain even on the opposite side. So the pathologies change automatically. You certainly start ruling out infective pathologies. So the site of pain and exact site. Sorry for this groin. It should not be. the onset, whether it is sudden or insidious, the duration, whether there are remissions and relapses classically seen in rheumatoids, what is the radiation like. At times, elbow pain radiates on the medial side of the forearm, which guides you that there is something happening to the ulnar nerve along with the elbow pathology. Is there any diurnal variation? What are the aggregating and relieving factors? And what is the progression over time? It started 6 months back. How is it today? And if you can objectively get down these pain characters from a scale of 0 to 10 in an intelligent patient, it gives you a good way of evaluating, especially if you have to call back this patient again to assess how your modality of treatment has helped him. So that was a bit about the history. So follow the normal things which are supposed to be done in history, and it will tell you, it will guide you towards some amount of a provisional diagnosis. Next is the examination, and as in any other joint, you will follow the look, feel, and move, and look at the functional disability. And once you do this in systematic way, you reach your answer. So let's take it one by one. Now, inspection of an elbow. It's of paramount importance that you look at the elbow from the front, from the side, from back, and from the inner side. And it is of paramount importance that you look at both the upper limbs together, meaning to do an inspection, it is very important to expose the patient from shoulder to hand on both the sides so that you can look at the elbow and compare whatever you're looking at on the normal side, because elbow is a very good joint. You have a normal comparator. So from the front, you want to look at the alignment, whether there is any scar swelling or whether there is any wasting in the arm and the forearm. As we move further in our discussion, I will show you pictures which straight away are glaring findings. If there is a severe wasting in a tubercular arthritis, you just can't miss it at all. From the outer side, again, you want to see the alignment. You want to see whether any bony prominences are standing out, like the lateral epicondyle or the radial head, or the olecranon, whether it is jutting out behind or below or something. So again, you want to look at the swelling or if there is any wasting or any scars or sinuses. From behind, there is an additional thing which comes into an elbow examination, which is the 3 points, the bony points, any fullness in the para-tricipital grooves. So this you can look at only from the back. Now, if the patient is very obese, these features might not be there, but you need to train your eyes to get into a drill of looking at them. So if you want to look at a cubitus varus or a valgus, you have to look at the alignment from the front. If you want to look at a olecranon jutting out posteriorly, you have to look at it from the side. If you want to see the tricep tendon standing out or a tricipital fullness, it is always looked at from behind. In a thin patient, you might be able to look at the 3 bony points from the back. And definitely never miss out the medial side, which is a common area which is missed out. And at times you are stuck. When you present your case, you suddenly find there was a small scar on the medial side. So on inspection, to repeat, look from the front, from the side, from behind, from inside, and please compare it from the normal side. So what is the important thing as far as your short cases is concerned? One very important thing about elbow is the carrying angle. Now, as we had talked about the anatomy, the trochlea extends more distally than the capitulum, creating a carrying angle, meaning the forearm is angulated slightly outward as compared to the arm in a normal anatomical position. So what is a normal anatomical position? A patient standing with elbow extended and the palms facing forward. So the normal in males is around 5 to 10 degrees and females around 10 to 15 degrees. Remember to comment upon the carrying angle. The prerequisite is that you should be able to get the elbow in extension. If there is a flexion deformity of 15 degrees, you should refrain from commenting upon the carrying angle. Understand? So prerequisite is the elbow has to be in extension, because that is when the forearm is aligned in an outer way as compared to the arm. So cubitus valgus is when the carrying angle exceeds 15 degrees. Cubitus varus is when the carrying angle is less than 5 degrees. Certain books would give you variation in this range. Some may say 17 degrees for valgus. Some may say 7 degrees for varus. Don't get excited if you are stopped on this. You should be knowing that there is a subtle difference in these range by different authors. Now, what happens between valgus and varus? It is suggested that if the patient doesn't have a normal carrying angle, meaning that it's a straight arm, so that is given a term as cubitus rectus, meaning a straight arm and a forearm in a straight line. So we've done the inspection. Let's move on to the palpation. We need to be asking the patient at this point, can I have a look by feeling your joint? Be very careful. Quite a few exams happen in the winter, and if you have not rubbed your hand and made them warm, it is very, very impolite to touch the patient with chilling hands. And to add on to it, if you do that, the patient might go into spasm because of your cold hands, and the various features which you want to elicit might become difficult. So please take a consent. In today's days, before palpating, even before examining, wash your hands, and then the first thing is you need to look at the temperature around the elbow joint, which is done by the back of the hand of the examiner. You look all around. You look at the distal part of the humerus, in the front, on the sides, on the back, on the upper forearm, to pick up if there is any place where the temperature is raised or not. At times there might be a subtle change, so you're not sure whether the temperature is raised or not. Always take the help of the opposite side and compare and see. So once you've looked at the temperature, look for the tenderness, which are the bony points. You look at the distal humerus, the lateral epicondyle, the tip of the olecranon, the proximal ulna, the radial head, the medial epicondyle, and the medial supracondylar ridge. Go in a systematic manner so that you don't lose anything from top to bottom, from outside to inside. Palpate all bony points by deep tenderness, and check whether there is any tenderness. You might be dealing with a patient which has a soft tissue lump, or meaning that you might be required to also palpate areas which are classical for soft tissue swelling. Those would be paratricipital. Those would be the Anconius triangle. So as you can see on the top right, the Anconius triangle is formed by the lateral epicondyle, the radial head, and the olecranon. And that is the area where the effusion of the joint or any synovitis is first to present. And so you can easily palpate any joint tenderness in that area. You also need to look around the other soft tissue, the ulnar nerve, definitely the epitrochlear lymph nodes. You need to palpate the cubital fossa. You need to palpate on the back, on either side of the triceps. On deep palpation, you might suddenly land up with something bony hard anteriorly, which might be a myositis mass sitting there. So you look for the temperature, you look for the tenderness, then you go on to the soft tissues, palpate all of them, and try to pick up if there is any abnormality. So in palpation, now the three bony points has a big relevance. So it is quite often in the exams asked from you to demonstrate how to palpate these bony points. So how to feel radial head? Keep the elbow in flexion, feel the lateral condyle. Below the lateral condyle, there is a fossa, and in the fossa, feel for a smooth, rounded, bony hard structure, which you confirm by supination and pronation. So as you can see in this picture, when you are asked to demonstrate anything, please do not stand in between the examiner and the patient. So when you are demonstrating, your arms should be placed in such a way and your body so that the vision of the examiner is not being blocked. So this is the way you're going to be palpating the radial head. The three bony points, the medial epicondyle, the tip of the olecranon, and the lateral epicondyle. Now, when the elbow is extended, they should be falling in one straight line. Compare it with the normal side. When the elbow is flexed, they form an isosceles triangle, flexed to around 90 degrees, meaning the intraepicondylar is slightly longer than the medial and the lateral limb. Now, most of the books, if you read, will say it has an isosceles triangle. However, your clinical examination manual by Dr. Das suggests that the medial limb could be shorter. We also have a few publications in literature. One has come out of PGI, which says that it is a scalene triangle and the medial limb is shorter. But for all practical purposes, I think if you say that it's an isosceles triangle, you are on the right path. So you would be asked to demonstrate how to palpate these points. So as you can see on the picture on the right, if you are asked to demonstrate an extension, please don't stand in between the examiner and the patient. So you might have to put your hand in a slightly awkward position coming from the inner side, putting the index finger on the olecranon tip, the thumb on the medial, and the middle finger on the outer epicondyle. How do you palpate these epicondyles? You palpate the supracondylar ridges and you gradually come down, and the most prominent bony point on the medial side is a medial epicondyle, on the lateral side is a lateral epicondyle. How do you palpate the olecranon tip? You try to identify the subcutaneous border of the ulna, gradually palpate and move proximally, and where the subcutaneous border ends and there is a bony prominence, that is the olecranon. Now, at times, these processes seem a bit stupid, but when there is a distorted anatomy, if you follow these protocols, the likelihood of creating mistakes is less. So you've done your inspection, you've done your palpation, now moving on to your movements. Now, movements in the elbow joint are flexion and extension, and supination and pronation. Again, if you refer various textbooks, there will be a subtle difference in the range. A complete extension of 0 degrees, it is called 0 degrees, it is not called 180 degrees. So if you describe a patient, it would be a flexion range from 0 to say 140 degrees. Or if it is restricted, it would be say, as in the right side example, from 30 to 90 degrees. And hyperextension of 0 to 10 degrees is considered normal. For that, always compare it with the opposite side. So if the patient has an hyperextension in the unaffected side, you take it as normal even on this side. However, if it is not comparable, then you would consider this movement as pathological on this side. So remember, the flexion arc starts with 0 and ends wherever it is, and there could be a normal hyperextension of 10 degrees. There are various ways of inspecting the range of movement. One of the ways is this. You make the patient to stretch his arms with an abducted shoulder at 90 degrees. You stay away from him and you can beautifully compare the abnormal left side in this patient as compared to the right side. On the left picture, you can see that there is incomplete extension. And if you look at the right picture, you can see there is incomplete flexion. So you can easily say, looking at this patient, the range appears to be 20 degrees to around 80 degrees. Now, it is important in any musculoskeletal examination, when you're assessing the movement, you check active first and passive next. At times, patient might not be able to do any active movement because of whatever pathology is there. So you do an active drill. If the patient is able to demonstrate that, fine. You again recheck with a passive movement so that you are sure there is no difference between an active and a passive. The same thing you can also assess by the patient facing to the right or the left, and then keep one shoulder slightly flexed and the other slightly extended. In that way, you're comparing both the elbows right in front of you, one top of the other. The next important thing is start putting the goniometer on the elbow joint from now on. If you practice it, you will be able to demonstrate in the exam properly. If you don't, you will fumble. So the goniometer limbs are supposed to be put on the outer aspect of the elbow, and whatever is the range, you lock the range and then note down what is the movement. Now the other movement is supination pronation. Now the neutral position is called the 0 degrees, and there is around 90 degrees supination and 90 degrees pronation. Again, in this, there are subtle difference in different books, but more or less both these movements are similar in a patient. The difference, if is there, would be a subtle 5 degrees more in supination. 5 degrees more in supination. Always remember to compare with the normal side. So if a patient has a restricted movement on, as you can see on the right side, you would say that he has a supination of 45 degrees and pronation of 60 degrees. One question is asked in the exam at times: what is the functional range of elbow you want for doing most of the activity of daily living? For flexion range, it is maybe 30 degrees to around 110 to 120 degrees. And in supination pronation, the rough rule is 50 degrees either side. So if you have a 50 degrees supination and 50 degrees pronation, you would be able to carry out most of the activities of daily living. So that's a way of evaluating the supination pronation. You flex the elbow at 90 degrees, tuck the elbow on the side of the torso, and then ask the patient to hold a rigid pen or a scale on his hand and demonstrate supination and pronation. The best way is that you yourself demonstrate this to the patient, then he would understand very nicely. Please re-emphasize that the patient should not hyperextend or flex the wrist joint in an abnormal position. It is not a very bad idea to have two different colored pens on either side, and especially when you're asked to demonstrate, and you can easily say your examiner that, sir, on the right side where the pen is red, the supination is exaggerated and pronation is restricted. So how to measure objectively? Use a goniometer. If you're looking for supination, put the horizontal limb on the volar side and the other limb vertical. And if you're looking for pronation, the horizontal limb on the dorsal side. So these need to be practiced. Finally, the measurements. These are for the arm length, the forearm length, the muscle wasting, and the carrying angle. Muscle wasting needs to be always done in a place where the muscle bulk is maximum. It needs to be done at a distance which is fixed from a bony point. So the proximal forearm is a good point. So you can measure maybe 7 to 10 centimeter distal to one of the epicondyles. And the mid arm is a good point. So you can measure from the lateral epicondyle, maybe 10 centimeters proximal. Compare it with the opposite side. So wasting, unless compared, has no meaning. So you need to compare it. And when a patient comes for a follow-up, the same side absolute number is also of significance. Carrying angle, you need to draw a longitudinal angle of the arm. You need to draw a longitudinal angle of the forearm. And the angle between them is the carrying angle as shown in this line diagram. The forearm is easy because there is a radial styloid, there is an ulnar styloid, there is a medial and the lateral epicondyle. So we have points. The central points of these are connected to make the long axis. The forearm, the proximal point is a soft tissue point. It is taken at the level of the insertion of the deltoid laterally and at the junction of the anterior axillary fold medially. So these two soft points, the center of this, and then you draw the line. Remember, practice drawing these lines, otherwise you would fumble in the exam. compare the carrying angle to the normal side. Arm length, you need to measure from the angle of the acromion to the lateral epicondyle. How do you measure the the angle of the acromion? You try to locate the spine of the scapula medially and walk laterally on the spine of the scapula. There'll be a point when the scapula spine suddenly turns anteriorly, forming the acromion. So that is the point. Mark that point, and you've already marked the lateral epicondyle, so you measure it with a measuring tape. The forearm length, it is measured from the lateral epicondyle to the radial styloid. Remember, the position of the forearm needs to be comparable on both the sides. If you change the position of the two sides, there could be an error. Special tests are not very important as far as your exam is concerned, because they would be for specific diseases like tennis elbow, like a posterolateral rotatory instability. However, your examination is never complete unless you've done a distal neurovascular evaluation, unless you have asked for what functional disability specifically if the patient has come for a functional disability. He could be a chef and then he might be having a problem in cutting large size watermelons. So you know that there is some issue on the extensor power, or there is some extensor instability. So these are the presentations which are going to hit you in the exam. In the elbow case, it will either be a swelling, a deformity, a stiffness, or a painful elbow. As I've already told you, the chances that you get a painful elbow is 1 in 4. What would be those cases? Those cases would be a cubitus varus, secondary to a supracondylar fracture malunion. You would have a cubitus valgus, or ununited lateral condyle fracture of the humerus. You can get a neglected posterior dislocation of the elbow. You can get a stiff elbow due to various causes which you need to elicit during your exam. And then you can be given a case of a swelling around the elbow. So as you can see the blue arrow, as you move from the right to the left, the conditions are painful. So the 4 questions you're asked in exam: what is your diagnosis? Why do you say so? What else can it be? And what do you like to do for it? So be prepared for these questions before you jump into the Viva. Don't start thinking when you are asked for the first time, because in a short case Viva, the time is limited. It's either 10 minutes or 15 minutes. The more questions you answer positively, the more marks you would accumulate. So if you do your relevant history, you do your look, feel, measure, move, and functional disability, you're likely to reach to the right place. So if you break down your examination points, you would realize that it is like a mathematics jigsaw puzzle. If you put each point of the puzzle in the right place, it is a diagnosis straight away. So if there is a 3-point asymmetry, it could be a T fracture, a Y fracture, intercondylar, or a lateral condyle humerus fracture, or a medial condyle humerus fracture. If there is a forearm length issue, meaning it has become short, it is a feature of a posterior dislocation of elbow. If both the supracondylar ridges are irregular, it's a supracondylar fracture. It could be a T or Y, but then T or Y will give you a 3-point asymmetry. And as soon as an issue of movement comes in, meaning that movement is limited, you start thinking of infective pathologies. So let me summarize these talks on the pillars of what we have talked till now, and give you a quick summary of what you're going to see in each fracture. A supracondylar fracture malunited will present on inspection itself as a cubitus varus. So it's a common presentation of this fracture. You need to compare it with the normal side. The 3 points are maintained. I have put 3 stars over there. We'll talk about it. There is thickened supracondylar ridges, both medial and lateral, and you need to compare it with the normal side. In the range of movement, all the range are important. There is hyperflexion and limitation of flexion. This is because of a classical extension type of malunion of a supracondylar fracture. Range of supination is more and pronation is less. This is due to the malunited medial tilt of the distal part of the fracture. Range of movement of the shoulder, there is increased internal rotation. This is due to the malunited distal humerus fracture, which is united in internal rotation. Now, supracondylar humerus cubitus varus is a very important case. So let me give some more details on it. Now, this is the 3-point relationship. You can see on the top in the middle, there is a diagram. There's a line diagram which says M for medial and L for lateral. So there is an angulation which is pointing laterally, and there is a tilt which is there medially. Please be very clear on these terminologies, angulation and tilt. The angulation is lateral, the tilt is medial. This is what happens. Look at the lady on the left. I will click it once more. The fracture goes for a medial tilt. So the whole triangle is tilting medially, but the triangle as such is remaining same. Same thing we'll see on the schematic on the right side. Now you can see the triangle and the whole thing moves medially. So in a supracondylar fracture, there would be a tilted triangle. Same thing shown from the back, the normal elbow and the abnormal elbow. See the triangle as tilted. A clinical picture showing that the triangle as a whole has tilted medially, but the points are related appropriately. Now, once this triangle tilts, it carries the forearm with it. So that is why the supination gets increased and the pronation gets decreased. Go back and read these things again and try to understand each direction has a relevance. Coronal plane, sagittal plane, and rotational plane. Right now, we are talking about coronal plane, meaning the medial tilt, which is represented in a supination pronation abnormality. Next is the rotation. So the medial rotation of the distal fragment leads to an impression that the internal rotation of the shoulder has increased. And there are various ways of assessing that. One you can see in this diagram, the patient is lying prone and you're lifting the forearm and comparing the internal rotation of the two sides. You can do the same by the patient standing. You can do the same by the patient stooping forward. The last movement is the flexion extension arc. Now, as you can see, there is an anterior angulation. I hope you can understand. The cream one is the ulna, the green one is the humerus. I have written anterior and posterior, and this is an extension type of a malunion where the condyles of the distal humerus go posterior. So in the flexion and extension arc, due to this posterior tilt, the possibility that there would be an hyperextension comes in. So because of a malalignment proximal to the joint, the ulna can move more in extension range than normal. However, because of this posterior tilt, the same would reflect into a similar degree of lack in flexion. So the range of movement remains same, but the arc changes, meaning it will be again 130 degree, but there would be 20 degree of extension and maybe 110 degree of flexion. Now this is because of the malalignment in the sagittal plane. Lateral condyle normally presents as a cubitus valgus. There would be the distorted outer bony point, so it will affect the intraepicondylar point and it will affect the outer arch of the outer line of the triangle. The supracondylar ridge, the outer one, would be irregular. There would be instability. There could be mobility of the fragment. Now, range of movement normally is preserved, but in a long-standing case, there could be some amount of flexion deformity coming in. And this creates a lot of confusion because of a combination of a valgus and a flexion deformity. So that's a malunited lateral condyle humerus. You need to describe x-rays. And then The other one is a neglected posterior dislocation of the elbow. On inspection, you can see the standing out triceps. You can see a prominent olecranon on the back. There is a flexion deformity. The patient cannot, the arc would be changed, even the range would be decreased. The 3 points are going to be distorted. They're actually going to be inverted, meaning the olecranon has jumped more proximally, you can say. The supracondylar ridges are normal. There's tenting of triceps, the range of movement I've already talked, and there is a shortening of the forearm. Why is it so? Because the olecranon has moved proximal to the humerus, and the measuring point is actually the lateral epicondyle. Intercondylar fracture is not a common injury in children. Invariably, if it comes, it will be an adult patient. They classically present with stiffness in the elbow. The 3 point would be distorted. The supracondylar ridges would be dissimilar, and the range of movement would be restricted. And as I told you, if it is a swelling patient, it is a painful elbow, you're moving towards an infective pathology, and it could be a tubercular arthritis of the elbow. And you look at this picture. There is a swelling, there is a flexion deformity. The 3 point become very, very distorted. It's a challenge to palpate them. You might not be able to palpate them. The temperature is raised, there is tenderness all around. There is severe wasting, there might be a scar, there might be a sinus which is active, and definitely the range of movement is going to be decreased. Now look at this. If you compare it with the normal side, you just can't miss a wasting of the arm and the forearm when there is a long-standing infective or inflammatory pathology. The tubercular arthritis of the elbow looks a very classical picture. It's like a boggy swelling, and there's a wasting proximal and distal. There would be a flexion deformity. There could be a scar sinus, and the patient comes with a pain and inability to move the joint. So those are the X-ray on the top. The left side is a pre-treatment X-ray, and the right side are the post-treatment X-ray. And on the bottom, you can see and compare the range of movement, both the flexion extension arc and the supination pronation. So now I've presented you in detail a plan for evaluation of the elbow. You can add, delete, you can change according to the case scenario. You might get a case of a tumor from a distal end of humerus. So your case evaluation plan would change a bit according to a examination of a swelling. However, in more often than not, you would be required to follow this plan. I think I'll stop here because it's been 40 minutes that I've been talking, and if there are any questions, we can take them, and if there is a desire, we can take few X-rays after this.
Thank you, sir. Thank you very much for such a nice and elaborative presentation. I think most of the things have been clear to all the postgraduate students, but I think still there are some questions pouring in the chat. Till we get more questions, and first of all, I would like to just know about a few things. When we are asking the student in the examination to measure the carrying angle, of course, while making a clinical examination, they are examining clinically, but sometimes the X-rays are being given to them. The measurement is slightly different. So what should be the exact procedure, and what should be the appropriate carrying angle measurement in that condition, whether it's a radiological or the clinical one?
Now, both are appropriate. Now, if there is a subtle difference, you need to draw your lines and see clinically whether there is a change in the carrying angle. But if it's a grotesque deformity, you know that there is a severe varus or a valgus. So as a protocol of evaluation, you need to draw these lines for clinical evaluation and make your diagnosis accordingly. However, if you have already passed your exams and you have reached the state where you are going to operate upon these cases, and you want to actually calculate the wedges and all, at that point of time, the radiological evaluation of the specific wedge size or the degree of angulation becomes more specific for the treatment. So as a postgraduate, you need to know both. You need to know the relevance of the both. You should not go with the thought that these would be more accurate by X-ray, so I will not do them in the clinical examination.
So most likely they should be almost similar, or they should show the difference. Usually we get a slight difference in the measurement. So is it always there?
No, it should not be there. It depends upon the learning curve of the student. It depends upon the severity of presentation of the patient. You see, if there is a very obese patient with a BMI of 60, it becomes
Right.
a challenge in palpating bony points. So your markings
Exactly.
can go haywire. But then if it is a thin, skinny person and you have been doing these drills, there should not be a major difference in the calculations.
Exactly. That is the main problem, because in obese patient we generally have some difficulty making them clinically. But of course, then the radiological part is always there with us. Thank you. I think Dr. Harmesh has got one question for you. Dr. Harmesh, would like to ask, or should we go ahead?
Please ask.
Dr. Harmesh, are you there?
Yeah,
I
sir,
think
good afternoon.
yeah.
Yeah, so I
Yeah,
just
you
wanted
can.
to know that is it necessary to be able to extend the elbow fully before we can comment on the carrying angle? Or if there is a slight 10-degree flexion deformity, it's okay.
So on the protocols of clinical examination, it is a prerequisite that you should be able to extend your elbow to comment upon a coronal plane malalignment. However,
So that means if there is a flexion deformity, then the PGs should not comment on carrying angle. They should say, I am not able to comment because of the flexion deformity.
so let me complete.
Yeah.
So, however, there could be scenarios in which there is a 70 degrees valgus deformity and a 30-degree flexion deformity around the elbow, which has happened due to a malunited, non-united lateral and lateral condyle humerus for the last 15 years. This classically happens with lateral condyles. So when the patient is made to stand in anatomical position and the grotesque deformity is shouting at you that it is present, it should not be a desire to keep jumping on this fact that I'm not able to extend it. However, you should be able to convey this fact to the examiner that you know that to judge a coronal plane alignment, extension is desirable. So my answer in this severe situation would be that on inspection, this patient has a severe valgus deformity on the right upper limb. However, on further examination, I found that there was a flexion deformity, so my evaluation could be erroneous. Got my point? So you need to make the examiner understand that you know that there is a prerequisite, and there is a prerequisite, so we need to follow it. It is based on the anatomy. Only when the proximal ulna comes into the distal articulation with the trochlea, the carrying angle gets manifested. Once it is flexed, the carrying angle is lost, because once you're flexed 90 degrees, the difference in the proximodistal relation of trochlea and capitulum goes away.
Right.
Right. I think Harmesh has given another query. Like,
Dr. Vineet, can I ask a question?
hello, good afternoon. Yeah, sure, sir.
Good
Sure, please
afternoon,
go
sir.
ahead.
How are you?
Good afternoon. I'm fine, Dr. Dr. Lalit, as usual, excellent lecture. Just one point I wanted to clear. When you measure the movements of supination pronation, the neutral you take like a mid-prone position which you are showing, or should it be full supination from where you take 0 and then measure it?
Mid-prone.
The anatomical position of a person would be full supination when you stand.
I know. So if you challenge that question to an anatomist that the anatomical position is palm facing forward, you can. But if you look at all the clinical manuals, they take the mid-prone as a 0.
So mid-prone should be taken by postgraduates as 0
Yeah.
and then measure.
Yeah.
Thank you.
Right. I think the another question was, I think Dr.
Dr. Vineet, is it possible if I can ask a question?
Yes, pleasure.
Lalit sir, when the patient has a malunited supracondylar fracture, we always say that the internal rotation at the shoulder is increased, right?
Yeah.
Which is because of the change in the arc of motion. How do you actually demonstrate it? Because most of the times the students get confused trying to demonstrate that. So what is the right way of doing it?
Good. I think this is a very, very important question. Students get stuck both on the pathophysiology, pathoanatomy, as well as the demonstration.
Right.
So let me repeat the pathoanatomy also once. Try to imagine the malunited supracondylar fracture as a chisel on chisel thing. You place one chisel on top of other chisel, and the distal chisel is internally rotated. So as soon as that happens, it tends to fall into medial tilting because of a triceps pull on that side. Now, once this happens, there is a malunion in rotation. Now, once there is a malunion, the distal humerus is in continuity with the shaft of the humerus and the head of the humerus, meaning it is in continuity with the shoulder joint.
Right,
So
sir.
anything which happens distally will get manifested in the shoulder joint. If you want to exaggerate this whole situation, if you have a malunited mid-shaft humerus fracture, which is malunited in internal rotation, say of 90 degrees, then if you check the movements of the shoulder, that 90 degrees of malunion would get manifested in the humerus movement. So in a supracondylar fracture, there is around 10 to 15 degrees of internal rotation deformity. So that is why it gets manifested when you demonstrate the shoulder movement. Now, one of the classical ways, and there is a named test also, the Yamamoto test, in which you make the patient bend forward and you place his forearm, both his forearm on the back, meaning that the elbow is flexed and the forearm is perpendicular to the torso. And then you try to lift both the forearm and see. If there is internal rotation malunion, the forearm would be raised more, meaning that the internal rotation has exaggerated. Now, in my video, the next slide is actually a video which demonstrates all this. And you can do the same thing in a prone position. Make the patient lie prone and lift the forearm, and that will tell you a comparative. You can do the same thing with the patient standing and the shoulders abducted 90 degrees. So these are the three ways in which the shoulder movements can be manifest.
Right. So thank you.
Right, Rehan. Rehan, is it clear now? Okay. Hello, Maini sir.
Yeah.
There was one question. What is the idea? Because as you said, the purpose of elbow is to make the hand functions of hand more easier. And what is the ideal position of elbow orthodesis?
That's a chapter in itself. So when we have a seminar on infection and orthodesis, we will definitely address that. However, now this is a classical question which is asked, and this question needs to be addressed depending upon which upper limb you're handling. Meaning the dominance is very important here. Now, the dominant limb is normally used for feeding yourself, and the non-dominant limb is normally used for perineal care. So depending upon that, in a dominant limb, you want a flexion position, and in the non-dominant limb, you want a slight extension position. So a classical would be a dominant limb would be a 90-degree flexion, and a non-dominant limb would be a 110 degrees of it will be around 70 to say 60 degrees of flexion, meaning your elbow is opened up a bit so that you can reach your perineum. And regarding the supination pronation, both the dominant or the non-dominant, you try to keep them in the neutral position or the mid-prone position.
Dr. Maini, may I ask
something? Yeah, please. You want to add on something also to this? Because you have answered on the chat. I just saw your.
Yeah. Dr. Maini covered everything very excellently, and I always appreciated his teaching abilities. There's just one thing which I think is important in measurement, that in forearm column, it is important to measure the length of the forearm from both the medial side as well as the lateral side. In some malunited fractures of the Montigia fractures, particularly in childhood, the medial column length and the lateral column length compared to the other side will be different. So a difference in the medial column of the forearm and the lateral column, that is the length from the lateral epicondyle to the radial styloid process compared to the other side, and the length from the medial epicondyle to the ulnar styloid process compared to the other side. The variation will be different in cases of malunited Montigia fracture. What do you say, sir?
I think that's a very good take. However, this is for advances in orthopedics. Now, definitely these measurements are described. They are also described actually for the arm length. So they suggest that even the arm length, the forearm length should be measured both medial and lateral. However, these are newer concepts which have come in, and they are not classically available in most of the manuals. So if a person is able to tell about the medial lengths, he's definitely given more marks. However, if he is not able to comment, you don't give him a negative point. These measurements are definitely useful, have a role, and if done, give you an extra point. So if you want me to describe the humerus length, so if you have to measure the medial humerus length, now the distal point is okay, it's the medial epicondyle. The lateral point, the proximal point is a soft point. Now again, this is a point where the anterior axillary fold touches the arm, or it is a point which is exactly opposite to the attachment of the deltoid. Now, both these points could be variable and might be slightly difficult in obese patients to pick up. However, the anterior axillary fold meeting the arm is invariably markable. So yes, you should and you can, and they would give you certain more inputs about a complex case.
Yes.
Can I ask Vineet one question?
Yes, Dr. Samit. Please go ahead.
Many sir, my question is, in a short case, when you said there's a limited time, is it mandatory for the examinee to, in a case of elbow, to examine the shoulder as well as the wrist? Or is it just an additional thing? If he does, it's good. If he doesn't, it's okay.
Like if it's a cubitus varus, I want him to check the rotation of the shoulder. However, if it is a normal elbow case, I would not be pushing him on checking the ipsilateral shoulder and the wrist. His wrist function, I would assume, has been checked because I do want him to check the distal neurovascular. So I've expected him to check all the 3 nerves. So I'm not going to be asking him on details of shoulder and wrist.
No arm in a cursory kind of,
Definitely, like the patient I had showed you of this tubercular arthritis actually had TB of the shoulder, elbow and wrist both. Now, in such a case, if you are totally silent about the wrist, it's a disaster. A boggy swelling is visible over the wrist also. You can't be quiet about it.
Correct. Thank you.
And sir, would you like to show your presentation now? I think there are some a few slides have been left. Can you go ahead with that? Yeah, please.
Yeah, I'll try to run through this and see if I can show you the rotation. We'll not do the whole video. I'll see whether we can. These videos are already there on YouTube, so you can go and have a look. So that's one way. If you don't have a pen, you can use your thumb and fingers. Now this one I was talking about shoulder movement. This is one of the ways. And we like to do it from the side because we are able to look at the forearm and compare it with the opposite side, whether which is going more or less. This is one of the ways in standing position.
Right.
And this is the lying down position. In this, you have to be careful that you do not flex or extend the wrist to give a wrong impression. So that's the arm length. In slightly obese patients, you might have difficulty in palpating the spine or scapula, but you need to practice that and you will be able to do it. Elbow instability, you should quickly check abnormal movement of any joint. That is done both in 0 degree and 30 degrees, and especially in lateral condyle humerus, you might be having it. And regional lymph nodes and ulnar nerve you need to do. So let me take you through a few x-rays in 5 minutes, which tell you about the basic radiology. We've already done a radiology seminar, but just re-emphasizing because there are certain questions which are specific to elbow. Now we need to know what is a normal AP and a normal lateral, because if the projection is not appropriate, you will pick up abnormal things. You will feel that there is some sclerosis or some lysis. So you need to be looking and understanding what is a normal AP view in which you are able to see the whole profile of the elbow joint, which is like a very nice, gentle, curvilinear wave of a river. So this is a classical, beautiful AP view, and you need to follow all bony points from lateral to medial as we done in our clinical examination. The lateral views are a bit difficult to get. They are invariably oblique. Now you should be able to pick up this round capitulum and the hourglass constriction above that. Now, if that is there and you can see both the cortices of the humerus, it is a true lateral view. And you should remember the relation of the radial head with the proximal ulna. There is slight overlap over this. So if you combine all this, then you are sure that your projection is right. Because if your projection is inappropriate, that itself could give you an abnormal sign like a abnormal fat pad or a abnormal crescent sign. We need to practice our eyes to look at X-rays of children, because they would have ossific centers which would not have fused. They would have epiphyseal plates over there, which at times could be confusing when there is an injury to the elbow and the patient is pointing for pain on the same area. Both again, we need to practice looking at the AP and the lateral. You see, there is no overlap in the lateral view in the capitulum and the olecranon. And we should remember that there is a ossific nucleus of the olecranon, and this is not a fracture. Ossific nucleus, remember the creto, you might be asked this in the exam, the capitulum, the radial head, the internal epicondyle, the trochlea, olecranon, and the lateral epicondyle at 1, 3, 5, 7, 9, and 11. So you need to practice this to know this. Suddenly you might have a case in which the lateral epicondyle is not visible. So you need to know all these things. So the distal hourglass is very important to identify to understand the projection is correct or not. And if like for in this example, it is not correct. So you know that there is something which has happened to the distal humerus. There is either a malunion or there is some abnormality in projection. However, if you compare the ulna, if you compare the overlap of the radius, if you look at the humerus cortex, it appears that the projection is not very appropriate, very inappropriate. The fat pad signs, they might not be there, and they become visible when there are subtle injuries or hairline fractures. These are the normal fat which is lying in the fossa anteriorly and posteriorly, and due to the hematoma, they get pushed forward. And the anterior fat pad, as you can see in this, the black one is like a sail sign, sail of a boat. So it's called a sail sign. So if there is no fracture line visible and suddenly the fat pad becomes very prominent, you are thinking that there is a fracture there, and the patient needs to be managed accordingly. The anterior humeral line is important. It tells you about a malunion in the sagittal plane, and normally it passes through the capitulum, and if it is not, there is a problem there. You can see here, there is a malunion in extension. So the anterior capitular line is going anterior to the capitular epiphysis. Again, the radiocapitular line is very important. A line drawn along the shaft should go through the capitulum, and if it is not, there is some abnormality, you need to go into the details. Like this is normal, it should be like this, but this is abnormal. So if you draw a line along the radial shaft, it is not going through the capitulum, both in AP and lateral. The radius is anterior and lateral, and if you look carefully, there is some fracture over here, some angulation over here. So this is a Monteggia anterior type. The crescent sign, which is a sign which can be asked, which can be projected in the exam. Now you look at this. This is a normal elbow of a child. The anterior, the posterior cortex, the hourglass, the anterior capital line going through this, the radial line going through, no overlap. On the AP, there is a subtle fracture. There is a subtle fracture. Now, this is a crescent sign. Because of the medial tilt and the rotation, there happens an overlap of the capitular epiphysis with the ulna trying to create a lunar type of a overlap called the crescent sign. However, the radial head would continue to be in the same line. Bowman angle, again a lot of confusion, which is the Bowman angle, the larger one or the shorter one. All the postgraduates should search the classic article and read in that. Now this is the perpendicular along the humerus and a tangential line along the lateral epiphyseal plate, the capitular epiphysis, and the angle between that, the alpha angle, is called the Bowman's angle. It would have a range. It will be somewhere between 60 and 80, and there are certain people who measure the other one, the 90 minus alpha, which is of the range of 10 to 14 degrees. So remember how to make it. At times you might be shown an X-ray in which is made wrong, and you might be asked to comment about the Bowman's angle, and if you start saying it is increased and decreased and is actually made wrong, you'll get caught. So this is a comparative calculation in a case of cubitus varus. If you see on the right side, the straight line along the humerus, the tangent drawn, and the angle is around 90 degrees. And on the normal side of the child, the same thing drawn, it is around 64 degrees. If you do the 90 minus alpha, you will get somewhere around, maybe around how much you'll get, 6 plus 16 degrees.
26.
26 degrees, sorry. So this is the Bowman's angle. Don't get confused on it. It was of great help. Its significance has become more academic because more methods of deformity evaluation and correction have come in. So I would conclude that history, examination, investigation would make the pillars of treatment. If you follow them in a systematic way, I think you will be coming to a correct diagnosis and doing well. Thank you very much.
Thank you, sir. Thank you very much. I think the more the things have been now clear to all the students, and even the faculty also has been gained a lot with your expert presentation. Now it's open to all the panelists. If anyone would like to ask any question, because I could not see any more questions in the chat.
So there is one question in an exam which is asked. You might have a cubitus varus in which the 3-point bony relationship is actually distorted. Now,
Right.
this can happen in exam. Most of your other findings are fitting, like there is supracondylar ridges are thickened, there is a cubitus varus, there is hyperextension, there is limited flexion, the rotation is increased, but the 3-point relation is distorted. Now it has been seen in long-standing patients, especially 2 to 3 years or 4 years, due to the mechanical advantage to the triceps, which starts lying slightly medially, the growth on the medial side starts getting distorted. So due to the persistent pull of the triceps on the medial side, there could be a scenario in which there is a medial limb of the isosceles triangle which is shortened.
Sir, I think one of very common questions which the postgraduates are asked is how are you going to take an X-ray to calculate the Bowman's angle in a supracondylar fracture. So that means the patient has a fresh supracondylar fracture and you want to take an X-ray. How do you do it?
That is why I was saying now Bowman angle has actually become more of historic value than of value in diagnosing or managing, especially in acute scenario, because in a supracondylar fracture in an acute phase, the child will be holding his elbow in around 30 degree of flexion, and in an age group of 6 to 8, these children, you cannot touch them. They will not allow you. However, if you are still sort of wanting to do it, when you're doing the AP view, you can still keep a support under the forearm and try to concentrate on getting the AP view properly, and that gives you an idea, because you're focusing on the distal humerus and the AP view.
All right.
Dr. Maini, in regard to this, what is the need of taking a Bowman's angle in an acute situation before reduction? I mean, how is it going to help us? I mean, you reduce it and then you check it whether the reduction is adequate and compare to the other side. What do you want to take in an acute situation?
If you really want to find an answer to this, maybe there is a severe sort of an impaction fracture and no X-ray lines are visible. The fat planes are just not visible, and there is a plus minus tenderness on the medial side, and the injury is 7-day-old. This could be of some academic use in telling you, if you compare it with the normal side, that it's going here and there, or even the absolute value. But I agree with your point that the role definitely in the acute scenario is pretty minimal. In the OT, when you're doing a reduction under the C-arm, definitely you can see it and check it. But even there, I don't think any of us are actually calculating the angles intraoperatively.
Yeah, nobody's calculating it because of the use of the C-arm the next test. Dr.
go
Mochit,
by
you
the-
want to add on something?
You actually go by the clinical judgment on the correction that you have retained, and then the gross profile on the AP view and the X-ray.
I think
Right.
just to add on to that, I think there are two indications, sir. One is when you have done your reduction, like in the theater, you have done your reduction and you want to be sure about whether you have been able to get that reduction. Probably that is the time when an AP view is needed. And the other is when you have done a reduction and you have fixed it with cross K wires and the patient comes to you after 7 days and you want to be sure whether the reduction is still holding or whether you have lost that reduction. That is the time when you will be trying to look at the angles as compared to the opposite side.
So it is a good angle that it is not dependent upon the forearm. It is not dependent on the opposite side.
Right.
So if you want to longitudinally follow a patient, it would definitely help you.
Yeah.
Yes, that's very true.
Rehan, some
So
more
one more
basic
question one more question I got on my WhatsApp. One of the post-graduation wants to know which is the most common complaint of the patient in case of elbow. It's a decreased range of movement or the pain, or both are equally important.
Come again, I couldn't get the question.
One of the PG want to know which is the most common complaint in case of elbow. Is it the pain or the decreased range of movement, like stiffness of elbow? So the patient comes to you, which is the more common complaint out of this?
This is actually an epidemiological question. I can assure you, you will never get this as an MCQ, and you'll never be asked this question. But if you want to epidemiologically answer this question, probably pain and stiffness comes together in elbow cases, and 1 in 4 patients would have pain and stiffness.
1 in 4. Together, yeah. Sir, sir?
Maybe in exam, I think more commonly to get a deformity, a deformed elbow. As a case, that will be more common without maybe a bit of pain, mild pain or something, but mostly it will be a deformity which they'll get it.
Yes, that's very true.
Dr. Sharad is right, because we face this challenge. If you keep a painful elbow in an age group of say 7-8, you just can't examine them.
Don't
So in exam, more often than not, you'll get painless elbow cases.
Yeah, it's difficult. Yes, very true. I think if there's no more questions, so can I ask Dr. Shraddha Agarwal to give a vote of thanks to all the
It's a pleasure.
speakers and
Listen to Dr. Maini. As usual, I missed some part of it because of my commitment in the hospital. It was an excellent lecture as usual, and definitely we have gained out of it. And thanks to you, sir, Dr. Maini, for sparing your time. Thanks to Dr. Minocha to be there to give his inputs, and all moderators and Vineet and Rehan and Dr. Mehta and
Dr. Maninder, please.
Dr. Maninder is, I think, doing the technical part also at the same time, and all the colleagues who have joined and all the postgraduates who have joined us today for this webinar. And thank you very much.
Thank you, Dr. Sharad.
Thank you.
Thank you, Dr.
Thank you, sir. Thank you very much, sir. Have a good day, sir. Thanks a lot.
Vineet, we should rope in Dr. Lalit Maini, sir, more often.
He's always there with us. We have no doubt.
He is always there. Now he is a part of DOA. He is a DOA.
Always there.
Of course he is.